Good morning, everyone. Hi. I have this microphone, but I think you all can hear me, although if you need me to use it, I'm happy to switch on. But welcome. I'm Galina Espinoza, and I am the editor-in-chief of a digital brand called FlowSpace, which is dedicated to science-backed storytelling all about women's health in midlife. And we know we have a lot to talk about. The conversation around women's health has been changing in large part due to advocates like our host this weekend, Naomi Watts, whose product company Stripes Beauty offers all sorts of solutions, as she likes to say, from scalp to vag for women who are going through perimenopause and menopause. And what Naomi has done with Stripes Beauty is bring to the market a hormone-free option for the issues that women face. Our conversation today, however, is going to focus on medicational treatments and interventions that are available for women that we have not talked about enough. I don't think that a lot of women still have a lot of questions about. And two of those medications we're going to be talking about are GLP-1s and hormone therapy, which I have to say, when I go out to dinner with my friends, this is all I get bombarded with questions about. So I'm excited to have two of the leading experts on these topics, Dr. Suzanne Fenske, who is a board-certified OBGYN, and Dr. Alexandra Sowa, a board-certified internist and author of The Ozempic Revolution. Thank you, ladies, for both being here today. All right, I want to dive right in, and we're going to start with hormones, which is like the word that gets everyone buzzing. And like I said, when I do go out to dinner with my friends, that's all they want to ask me about. So you're going to help me figure out how to answer their questions by basically sharing with us, kind of what are three things you want women in their 40s and 50s to just understand about hormone therapy? What are kind of some of the basics that we should all be level set on?
Okay, so the basics. So when we talk about HRT or MHT, which is menopause hormone therapy, you're generally talking about estrogen and progesterone, right? Those are the core basics of menopause hormone therapy. If you're a woman who still has your uterus, then you need to be on progesterone to support the uterus and prevent against uterine cancer. If you don't, then you don't necessarily need to be on progesterone, although there are other benefits to progesterone, which hopefully we'll dive into as well. So estrogen replacement therapy, I think that one of the main things that I hear a lot is that women believe that they can only start this when they're 1 year with no period. And they're told this over and over again by a lot of the doctors and providers that they see, and they come to me saying the same thing. I know I can't be on it yet. I have to wait 1 year, no period. So important to know that you can definitely start hormone replacement therapy during perimenopause, which is while you're still having a menstrual cycle, whether it's regular or irregular, which can definitely help with the transition.
And I know that a lot of women go to their doctors to talk about hormone therapy because they're experiencing real changes in their health. And Dr. Sowa, I want you to share with us kind of some of the metabolic health issues that women do face as they move through midlife, a lot of which comes as a surprise. Suddenly you have high cholesterol and you're like, literally nothing has changed. So what are you starting to see in the blood work?
It's so frustrating. And there's so many similarities between what we're going to talk about, namely that the medical institutions traditionally have kind of told you that, oh, you're doing something wrong. And it's like, no, this is actually biology. And as we move through these life cycles of a woman's life, our biology changes. And weight is not just about willpower, which traditionally we have been told, and like, you're doing something wrong, try harder, eat less, move more. But really, weight and the metabolic things that come along with midlife is really a biological change. And obesity is neurohormonal dysregulation. It's a big word, but I use it in all my lectures because I want people to know that it's not just a matter of what we're eating. So what happens as we go through this life transition, our estrogen decreases, insulin resistance rises, and the way that we package cholesterol within our own bodies changes. And so all of a sudden, you could have been someone with low blood pressure, low cholesterol, normal weight your whole life, and then boom. And you're like, I've done nothing differently. And so many women come to me and say, well, really, like, no one believes me, but I'm still going to the gym. I'm eating the exact same way, but my doctor said, well, just, cut out all meat and just go to the gym 2 hours more. And you're like, what? So it's really important to look out for these things and know that we can treat them and have interventions. And GLP-1 medications have been so phenomenal in helping us identify and treat and kind of validate that this is not just a willpower issue. And so regular screening is important, and then just believing the individual is very important, and then offering them treatment solutions that work alongside the things that are happening. I think insulin resistance is one of the number one things that's misunderstood in weight management. We don't traditionally test for insulin resistance, and you can very easily and cheaply, actually. You can just test for a fasting insulin and pair it with your fasting glucose, and it helps us predict far earlier the development of prediabetes, which is something that really surges in peri and menopause.
Yeah, and let's talk about timing, because I think one of the things that certainly I was surprised to discover is how much earlier all of this stuff starts to happen. Because you think menopause, you think, oh, that's like what my mom went through when she was in her 50s, and then suddenly you're like, wait, this feels like something is changing for me. So we've mentioned perimenopause, menopause. Dr. Fenske, can you explain the differences between the two? Because I also think people have started to conflate these things and think of it's all the same, but it's not the same. So what do we need to understand about these two very distinct transitions?
No, I think it's really important, actually. I mean, for me personally, I went straight from postpartum into perimenopause. So you have to kind of know that it starts earlier than we think it does. Menopause, by definition, is 1 year, no period. So it's a kind of a horrible definition, right? Because if you're someone who's had a hysterectomy or you have an IUD, you don't know what that 1 year really is. But technically, 1 year, no period is menopause. The 4 to 10 years leading up into that point is perimenopause, right? So if the average age of menopause in this country is 51, then think back. Right now, perimenopause can start in your early 40s, but perimenopause can start in your mid-30s, okay? Because the normal range of menopause is 40 to 60. Most women are gonna go through it between 45 and 55. So count 10 years back, we're talking about our 30s now when we'll start to see the changes. And the changes start early, and they're very, very different. The changes of perimenopause really change based on the phase you're in. So in that early transition, a woman may still be getting her cycle regularly, but all of a sudden she's noticing things. Her PMS symptoms have gotten a lot worse. She's ragey, leading up into her, to put it mildly, to lead up into her period, right? So that might be one change that happens. Weight can start happening at that point too, because now you have this imbalance of your progesterone and your estrogen. And then as you go through, I always call the kind of mid-phase is just pure mayhem, right? That whole mid-phase of perimenopause, cycles can be coming twice a month. They can be the heaviest cycles of your life, and then you're skipping a cycle. 1 month you're raging, the next month you're hot flashing, it's all over the place. And then you get into the later stages of perimenopause, and this is really marked by when you start skipping your menstrual cycles until you get to menopause, which is 1 year, no period. So it's really important to tune in and pay attention early, because if you wait 10 years for all of those changes to start to happen, even like what you were saying with insulin resistance to start to happen, now you're in diabetes. So you want to tune in really early and pay attention to the symptoms.
I think what's so amazing about everything you just said is that when I was in that age range, no one ever said the word perimenopause to me, ever. Like, I feel like this is only within the last 5 years or so. And the fact that, such a significant transition was completely ignored for so long is just, that's real rage. That's not hormonal rage. That's real rage. Dr. Sowa, we've talked about how weight gain, insulin resistance is one of the biggest symptoms that women report during this period. And I was recently talking to a doctor who, I don't know if she was serious or not, but she said that there's going to come a day where women hit 40 and they get a prescription bottle of GLP-1s so that they never have to experience that. But I think it speaks to how excited doctors are about the promise and potential of this medication. Can you talk through why it is so effective? I know it's been around for a while, but why is it only now that we're starting to see the efficacy of it for weight loss?
Yes. Okay, so many good things. So we've had these medications, GLP-1s, since the early 2000s. Why we've just come to talk about them is two things. I think it's when the weekly injectable came out, it was so much more effective for weight loss than even the daily shots we were using for over 10 years now. And it coincided with the rise of social media. So for a long time, I was standing on a soapbox saying, hey everyone, GLP-1s exist. And everyone would look at me like I was crazy and trying to sell them snake oil. And I was like, no, this is really the next wave of scientific advancement. But then when other women were on TikTok, specifically women first, and now men have joined, but they're on TikTok, they're on social media, and they're saying, look, I'm taking my shot, and I'm gonna take the stigma out of this. For so long, it was something in secret. Women, we knew that they gained weight through 35 to 50, and some was very significant, but there's so much blame placed on the individual because as a society, we value the inherent ability to stay thin as something that is virtuous.
And effortless.
And effortless. So if you need help or you're struggling, it was very quiet. And so I think the weekly shot that was very effective, I mean, upwards, we now have a weekly shot that can help people lose upwards of 25% of their total body weight, which rivals bariatric surgery. And it's weekly and it's easy and people are sharing. So that's why we're hearing about it now. And then since we've had about 20 years of data and so many people are on it, what's also happening is just the benefits are just, we're able to really study, not just retrospectively, but prospectively now and really follow people and show that we're having significant decreased rates of heart disease, kidney disease, progression to diabetes, decreased rates of dementia and cancer. And so it's really like a cultural moment. Okay, so that was the first thing. Oh, how do they work? Because the next thing. Okay, so why are they so amazing? Traditionally, we've historically had anti-obesity medications, so medications that could help people lose weight, and I still use them. But GLP-1s are so different because they're so much more than just an appetite suppressant. They work on the brain, they work on your GI tract, they slow your stomach emptying time so that you're full longer, but then probably the biggest benefit is seen at the level of the pancreas where you're really stabilizing your blood sugar. Stable blood sugar means decreased inflammation, and everything is able to operate and reset. And coming back to that neurohormonal dysregulation, we talk a lot about hormones and menopause. People don't realize GLP-1 is a hormone. We make it in our body. Now we've made a synthetic version. We're giving it to you, and then everything can start to operate smoothly again. And we could reverse the clock.
It's amazing to see how many gaps GLP-1s have filled when it comes to women in midlife. Dr. Fenske, what are some of the remaining gaps? I know there are a lot, so let's try to narrow it down to maybe 2 to 3 that you would love for there to be solutions for.
I mean, I think research first and foremost is the biggest gap for women. It's just the data is so lacking. Even when we talk about hormone replacement therapy, you know, you're lumping all the different types of hormones, oral, transdermal, as well as synthetic and bioidentical, all together into one and making assumptions based on that. So first and foremost, the most important thing for women and for really advancing medicine for women is going to be really advancing research in this. That's the main one.
Okay.
That's the hugest gap right now that we have.
All right, so let's all lobby to get more funding for research. Dr. Sowa, what are some of the myths that you see that people have about GLP-1s? You know, there is a lot of research, as you pointed out, 20 years of data, but there's still some misconceptions around these medications.
There's so many misconceptions and they dominate the headlines. I would say that people think it's an easy way out. There's nothing easy about taking control of your health. It is not a shortcut. It is a tool to help us achieve the healthiest versions of ourselves. And so I also don't want people to think, well, you just take it and then you don't have to care about your health. No, this is a part of many things that we need to do to optimize our metabolic health and to use this tool for longevity. I've really started to include when I give these lectures not only how amazing these medications are, but also we need to treat them with a lot of respect. And I worry that the pendulum has swung where there is a subset of companies that are trying to sell to women, use a GLP-1 and get your old body back. Use a GLP-1 and get skinny. And we have to really push against that because this tool allows us to step away from the toxic diet culture. And we need to continue to redefine that this is all about health. This is about longevity. This is about making our lives longer and better and not about thinness. So 2 sides of the coin there.
And all of that really applies to hormone therapy as well, which I do think is one of the areas that has the most misinformation in the women's health space. I know that I hear and see a lot of confusion from women about it. You already identified one key point of confusion, which is that you have to wait until you're actually in menopause, 1 year out from your last period, and you're saying, no, you can start it earlier. What are a couple of other misconceptions you think women have when it comes to hormone therapy?
I mean, I think I actually had a visit with a patient and her husband, I would say this past week, and it was really eye-opening because he was on in the visit too and talking about how, why would you recommend this for her? She's going to get breast cancer, right? And that's one big concern that comes into play. And that's for women, that is just our Achilles heel. You can bring up lots of things. If I brought up heart disease, if I brought up colon cancer, it's kind of like, oh, that's awful, but yeah, it's not going to happen to me. But breast cancer is just the way to invoke so much fear in women. Yeah. So that's right now for HRT. There's a lot of misconceptions. There's a misconception that you can only be on it for a set limited period of time, right? Which is why a lot of women are kind of holding off and waiting until, is this dire right now? Like, should I start this now or should I wait a little bit longer? And even in my training, and historically now, I've been practicing for 20 years, but we were told that we can only give it for 5 years and the smallest amount possible, and only if it's really, really dire can you give HRT. But it was totally discouraged then too. So now we know, right, that these benefits that we talk about with HRT, right, when we talk about decreased risk of heart disease, colon cancer, diabetes, dementia, osteoporosis, and even a reduction in all-cause mortality, that those things aren't going to continue past the time period that you've been on HRT. So HRT doesn't mean that you have to be on it for the rest of your life, but it means that you can be on it for the rest of your life. So that's another issue that's going on, is that we still sort of hold on to that old dogma that you have this finite period of time to be on HRT.
Yeah, and I think the fear of breast cancer, it's so real and it's so interesting because the number one killer of women is not breast cancer, right, it's heart disease. And yet we don't have that same sort of awareness or fear when it comes to heart disease. So I always find that very fascinating. And I think it shows how deeply embedded certain ideas can be, in the health space, lacking proper research.
Right, right.
Dr. Sowa, let's touch a little bit on the interaction between GLP-1s and hormone therapy, because for women who are interested in exploring both, what do they need to know?
I'm so glad you asked this. So you could insert GLP-1 into everything you just said, take out MHT, and I was like, yes, yes, yes. So, but interestingly, I'll go back. The other similarity with GLP-1s is that we're not exclusively studying them through women's life cycles. We have a dearth of research right now. We study women. Women actually do better than men on GLP-1 medications when it comes to optimization of health and weight loss, which is exciting because when has a woman ever lost more weight than a man when they set out to lose weight? So we are studying women, but not exclusively and for their life cycles like menopause, except recently we have 2 retrospective studies that look at women who are on GLP-1s plus MHT, HRT versus just GLP-1 alone. And we saw actually about a 30% increased weight loss when you combine GLP-1s with HRT. So it makes sense because we're talking about replenishing hormones that just go defunct as we age, and kind of you just don't hear the signal or they're not there anymore. And so couple them together and you're managing a lot of the symptoms that we've often blamed for weight gain, like you're just not sleeping well, or you're tired, so you're eating more. But also really it's getting to the root of treating insulin resistance and making everything work together. So honestly, they go very nicely together. What I do think we have to be careful of is just that everyone should be on all the things. And I do find that a lot of people are coming to me. Well, even before they ask, can I be on it? I think a big segment is talking about the breast cancer. Women who've had breast cancer are often totally left out of the conversation of hormone replacement therapy. GLP-1s can be an amazing tool for them. So I'm taking care of a lot of patients who after their breast cancer treatment, they're put on tamoxifen, which increases insulin resistance, can lead to a lot of weight gain. They can't kind of get the benefits from traditional hormone therapy. GLP-1s are their friend. And so even if you can't be on both together, I still see incredible success. And then what happens to the people who are like, I really don't need a GLP-1, I'm normal weight, and everything looks good, and I'm at the gym, and my body fat composition is great. I'm like, okay, girl, wonderful. And you don't need this drug, right? They're feeling like they're going to miss out because we're hearing about all these amazing longevity benefits. But as of right now, the research shows that the benefit is having to do with weight loss or prevention of gain if it's starting. And it's not just for overall health benefit yet. We just don't have that research yet. So not everyone should go rush to just get on.
Yeah, no, amazing. And I think that I know that you and I have talked about this in the past, but certainly medication is a part of the overall picture when it comes to maintaining your health. So Dr. Fenske, I'd like to start by asking you, what are some of the complementary non-medication interventions that you recommend for women in midlife?
Yeah, I mean, so my practice is integrative and functional gynecology as well. So I'm certified and trained in that and double boarded. So my approach is this, right? The answer to menopause and perimenopause is never just a GLP, just menopause hormone therapy, right? It has to be all the things. And I think it's so important that this is kind of an opportunity in our lives to kind of get back to ourselves and refocus on ourselves. And it's kind of coincides with that time in our life where we're focusing the least on ourselves and taking care of everything and everyone else in our lives. So it's kind of your call to action, right? So all those horrible symptoms that you're experiencing, view it as your call to action to focus in. It's not about, it's exactly what you had said before too. It's not enough to just do the GLP, to just do the hormone replacement therapy. You're not gonna feel wonderful, you're not gonna get the results that you want. You have to focus on all of your pillars, right? So you have to go back and focus in on your nutrition and optimize that and focus in on that. Focus in on your sleep, and on your stress management skills. So when I see a woman, I look at every aspect of them. So I will use supplements judiciously too, because we can take some of the data, right? There's kind of limited data on supplements, but we have some data, right? So low vitamin D levels can correlate to poor mood. So depression, anxiety that comes into place with menopause and perimenopause, you want to be able to implement these actions too. And this should not be blanketed, right? This has to be really specific to your symptoms and where you are. Optimization of sleep, right? So this is number one thing. No one's going to go out there and take on the world feeling like they've not slept and slept 3 hours and waking up with hot flashes and night sweats and racing thoughts and anxiety, which is what happens to everyone's sleep. So with that, really focusing in on your sleep. So even if it's a matter of using the tools, if you're having night sweats and hot flashes, it's not just about HRT. And like you had said, if you're not a candidate for it, there are other options that have been researched and studied to help manage those symptoms as well. There are other medications even on the market now, which we all saw during the Super Bowl.
Which was amazing. Let's just take a moment. Awesome. Menopause during the Super Bowl. Incredible.
But Veoza is a great option too for night sweats as well. And we can use them in breast cancer survivors as well too to really mitigate those symptoms. But you have to have a plan of attack in all aspects. You can't just jump on a medication and a pill and expect that it's going to change your life.
Yeah. Dr. Sowa, anything you'd like to add to that?
Samesies. Like, it's just, I think you're just not going to see the full benefit if you're just relying on a medication. It's why I wrote my book, because I have a holistic approach to this. You have to change your habits. You have to change how you're eating. You have to change how you think.
Yeah. Yeah.
Otherwise, this will not be long-term successful. Sleep, I look at all the vitamins, same thing. I don't know why we vilify vitamins in traditional medicine, but we do know that low vitamin D, B12, these things, when they're low, you have a hard time optimizing your both mood and the way that you're functioning. So I look at all of that. I also think sunshine, talking about vitamin D, I think just getting outside now, go take a walk. As the kids say, go touch grass. Like, I can't really, we've gotten so chronically online and inside, and I think getting rooted into just moving our body, it makes a difference.
All right, we're going to have to wrap up in just a minute, but one last question. As you look to the future, the next decade or so in women's health, I feel like we've got so much momentum, so many voices, Naomi Watts leading this movement to really drive things forward. What are you most excited about when you think about the future of women's health? What are some of the big changes you think are coming that we are all going to be the beneficiaries of? And Dr. Fenske, I'll start with you.
I think research is going to get there now. I think there's a lot more focus on that. We have right now all over going on with the FDA trying to take the black box warning off of vaginal estrogen. Yay, right? So this was a huge issue that we were having forever and that many of us have fought with. Even the breast oncologists that their breast cancer survivor patients couldn't be on vaginal estrogen. So they were stuck with these symptoms, of pain with intercourse, dryness, itchiness, frequent urinary tract infections, even leading to, sepsis and being in the ICU. So we're at least moving forward. Most importantly, I think that the biggest change that we're seeing is the opportunity now for women to really take control of their own health, right? Take it for themselves. And however you see that you want to control your health for the future, whether it's hormones, whether it's GLPs, whether it's medications, supplements, lifestyle, but at least now we have options, which is so amazing.
Dr. Sowa?
Again, same. I mean, really, it's like, it's good. It's good. No, it's great. Exactly. Exactly. So I think we're going to get more nuanced in how we treat women, and we're going to have more guidance. So specifically when it comes to GLP-1 usage in midlife, menopause, I want to know what is the right amount, how much is too much, how do we best protect our muscles, what is the optimal rate of fat to muscle loss specifically for women, and how do we really study this in this population and the benefits that go beyond. That's what I'm most excited about. I think we have new drugs in the pipeline too that are going to allow us to really pick what's best for you and your needs and your genetic makeup. That's thrilling.
I love that we've gone from virtually nothing to optimization and customization. Very exciting. Well, Dr. Sowa, Dr. Fenske, thank you so much for joining us today, and thank you all for coming out.